Good morning. So today we speak about prescribed minimum benefits. This masterclass is jam-packed with practical tips that will assist you in your business. So we're going to talk about two main themes. First of all, we're going to talk about the legislation that forms prescribed minimum benefits, and we're going to try and put that into practice, looking at specific examples. I want you to consider a couple of things before we carry on. And that is, what's those things that really bother you about prescribed minimum benefits? I've suggested a couple of questions, but you may have your own. You can go through these questions and have a look at them. Must I really comply with a PMB or a formulary or a protocol? What is a DSP? And must I use them? So there's a couple of questions, and I'm going to unpack that throughout the training, but add your own questions also to this. So when we look at MB cases, there was about 400 cases that was listed by the registrar on his website, and since 2000, and 141 of them relate to prescribed minimum benefits. 63 of those cases were adjudicated in favor of the member of 45%. Now, what I want to try and do with this training is to impart knowledge to you so that you can maybe change this equation and sway it more in favor of the member. So when we look at the philosophy surrounding prescribed minimum benefits, we first need to take a step back and look at how did we deal as medical schemes with benefits prior to 2000. And what we saw there is that prior to 2000, only the top options had certain rich benefits, covered chronic benefits, covered emergency, and covered certain hospitalization. At the lower end of the market, there was quite a lot of limits, lots of exclusions, and in most cases, medical schemes at lower end of the options didn't provide chronic benefits. And the legislator said no. In an environment of social solidarity, at every option, everybody must have a set of minimum benefits. And that is where this piece of legislation was framed. So we said there must be emergency treatment, there must be a set of hospitalization that is covered. That's a 271 diagnostic pairs that we find in Annexure A. And there is also the third one is a list of 27 chronic conditions that must be covered. Now, when we look at prescribed minimum benefits, we usually use in that a term that is called evidence-based medicine. And if I ask you what that would be, you would say it's not thumbsuck, it's properly researched, or you would use a sentence that explains it more or less in that way. So let's look at what is meant globally by evidence-based medicine. And there's basically two definitions. The one says that it is the conscientious, explicit, and judicious use of the current best evidence in making decisions about the care of patients. And the second one says the aim of evidence-based medicine is to integrate the experience of the clinician, the values of the patient, and the best available scientific information to guide decision-making about clinical management. Now that we get in the American literature, and we get it from the British Medical Journal, as I've referenced it there for you. But when we look at South Africa, how did we in South Africa define evidence-based medicine? And the normal definition is there on the screen. Evidence-based medicine means a conscientious, explicit, and judicious use of current best evidence in making decisions about the care of beneficiaries with the best available external clinical evidence from systematic research. Very similar to the definitions that we had in the past and your normal understanding of evidence-based medicine. But in South Africa, we have added a sentence, and that sentence is critical. It says evidence-based medicine must be integrated with the individual's clinical experience. Why? Because medicine is not an exact science. What works for me is not going to work for you. And for that reason, we need to make some exceptions. And when we go and look at Regulation 15I, we see that subregulation C says provision must be made for appropriate substitution of drugs where a formulary drug has been ineffective for cause or would cause adverse reaction in a beneficiary without penalty to that beneficiary. Now, that sentence, usually if a medical scheme interprets that by saying, we can't really approve this for everybody. We have our evidence-based medicine, and if we were to apply this exception to everybody, it would mean that we will go bankrupt. But does it actually say everybody? Because if I read that paragraph in the English grammar is written in a singular form, not in a plural. It doesn't say it must be to everybody. It says to a beneficiary and that beneficiary. So, law is written in a third person. If I were to change it to a first person, this paragraph would read as follows. Provision must be made for appropriate substitution of a drug where a formulary drug has been ineffective or cause or would cause adverse reaction in Andre without penalty to Andre. It doesn't apply to everybody. It applies to me. Okay, and that is what it says. There must be an exception for me, not for everybody. Everybody's clinical circumstances is not the same as mine. And for that reason, this section protects an individual in terms of where the medication is ineffective, of course, or would cause harm. Thank you.